9, don't panic. The last one, I just want you to look at, because you're going to see it as you go to NICU and Bethany, okay? So we're going to start off on page 296. Let me go ahead and get you to my slides.
If the mics are open.
Yeah. There was a question?
I have one. Will there be a discussion board post then, or just that assignment?
Okay, so remember, for every class you have an assignment. So respiratory is 2 different lectures, today and Tuesday. So that's only one assignment, but for attendance, there will be something I mentioned in the middle of lecture that you guys need to go and post to discussion board. And I will say, this is for attendance today, go to this lecture day and post the answer, okay?
Okay, thank you.
Welcome. All right, so apnea. Apnea of prematurity. The definition is absence of breathing for greater than 20 seconds. All newborns breathe periodically. They go 1, 2, 3, then they pause their breathing. Then they go 1, 2, then they pause their breathing. It's not real regular. Premature infants actually will wait a lot longer. So they will have a greater than 20 seconds. So when that happens, we've got to do something. I'm going to talk about why that happens here in just a second. On page 301 is what I'm getting ready to talk about. There's a good explanation. So when I take a breath in, I breathe in oxygen through my nose and my mouth. It goes down my trachea, goes down my bronchi, goes into the bronchioles. It's down to the alveoli, which are those little sacs. Those are those little sacs that actually the oxygen and carbon dioxide exchange. So we breathe in oxygen, we breathe out CO2. So when an infant doesn't have a full measure of their alveoli sacs, they only have part of them, or some of them don't even have enough, they're not inflated, or some of them don't have enough surfactant, because they needed to be full term, right? They were born before term, so they're preterm, and so they are not physically able to breathe usually on their own. So that's the whole purpose of the respiratory lecture today, is to look at factors that interfere with our body's ability to exchange the O2 and CO2. That's all respiratory is, okay? So what do? Whenever you did CPR and you had a patient that's laying on the ground and you would kind of shake them a little bit and go, hey, are you all right? Remember that. You're doing the same thing to the baby, but we're not shaking them. We take them, we rub their back, we rub their feet. So in the safety and security lecture, for some reason, is it on this one or the next slide? Hang on. Yeah, it's the next slide. I'm not going to talk about that yet. I don't know why your book did that, but it is kind of interesting. So we have to do something to stimulate them to breathe. There's lots of things going on that cause them not to be able to. Just know that. We're going to get more of it here in just a second. I'm going to mention some equipment that you may see when you go into the NICU or Bethany. A lot of times they have to have CPAP, which is continuous positive airway pressure. The baby can ventilate. The breathing is 2 things. We exchange, but we also have to breathe in and out. The baby can breathe in and out, but they need some more air to make those alveoli sacs stay open. Caffeine has a negative, caffeine is good. They give the babies caffeine. It stimulates them to breathe, but there's a yellow box on your page that talks about how you can have toxicity. So one of the side effects of caffeine is that it causes a diuresis, so they can get dry. So what are we going to be looking at to make sure, what is the nursing implication to make sure that baby is not getting toxic? We're going to make sure they can pee. Are they peeing it off? We're going to be checking specific gravity. We're going to be making sure they have enough wet diapers. Are they getting enough in? They may not be drinking orally. We may be giving them IVs, but how's their body metabolizing it? Okay, so here's that funny slide. this is on page 302. So when a woman is pregnant and she starts having issues, and you're covering that in the women's health, and it looks like she's going to deliver early, they can go in and do different tests to see how mature the lungs are. So to see if the baby is actually getting ready, if they have time. So one of the things that happens is they know that these two, lecithin and sphygmomyelin, don't memorize that. These are things in the body that are in their lungs, and if they have, and to begin with, they have more, I don't even remember, I didn't even know this, I had to look this up. They have more of one, and then they have more of the sphygmomyelin first, and then by 32 to 33 weeks, it starts getting more equal, and then towards the end, they have more of the lecithin, and that means that their lungs are getting more and more mature. They've discovered this, and they can go in and they can do amniotic fluid where they take it out from the mom. If her membranes have ruptured and they want to see how mature the baby is to see what they need to do to prepare for that baby. Are they going to have to get lifeline ready? Are they going to have a ventilator ready? They can go in through the vagina and get some of the amniotic fluid and test it, and it's pretty accurate. Let's see what else is on here. Oh, they can also do a maternal biophysical profile. That just is a combination of an ultrasound of the baby and a non-stress test. They look at all of it, and that gives them an idea of how the baby is actually doing in the womb. And then it says some risk of elective cesarean sections, which that means they don't get the squeeze, and steroid injections. And we're going to talk about that more in a minute when we talk about surfactants, so hang on to that. I want to pause for just a second and give you my little spiel. We post reading on your objectives. Those are a requirement. That's not a suggestion. You really do need to read the material. And I realize that respiratory is a long, big chapter, but if you will read it an hour a day, you will have it all done by next Tuesday. So that means, yes, if you have a 12-hour clinical, you're still going to have to work in that hour of reading when you get home or before you leave in the morning. Sometimes that means getting up early. So the reading really will help you. I cannot possibly teach you absolutely everything the respiratory lecture has. I can tell you, I can explain it a little bit better. You can ask me questions. I may refer you to a page number because I can tell you and you'll forget it. But if you look it up, you'll remember it better. Okay, so it's to help you. All right, so we're trying to figure out how mature the lungs are, so we've done all this stuff. So what is the nursing role on this? We're going to get to that. So respiratory distress syndrome is they've had trouble breathing, and they did not respond like we wanted them to, so now we're having to do something. So they get a lack of surfactant, and I was going to bring balloons and I forgot, but if you have a couple of balloons and you hold them together, they kind of stick together, especially if they're old balloons. They don't slide across each other very well. Well, let's pretend that a VLI is like a balloon, like two balloons. If that surfactant is like pouring olive oil on that balloon, and now they're sliding together, they're not getting stuck, so they can go in and out when you breathe. So the surfactant is vital for those newborns to have. This is on page 301. There's a good chart on 9.6. And you don't have to know this, but this is just a good way of seeing what does respiratory distress look like in the newborn. So one of the other problems they have, so they have lack of alveoli, they have lack of surfactant. Also, they don't have strong muscles. So think about it, when we breathe in and out, we have a rib cage and we have muscles on top of that. The baby's muscles aren't even ready yet. This newborn, this preemie, his muscles were not done. So I've had them come out of the womb at 27 weeks and breathe on their own for a couple of hours, but then they wear out. Their body that chemical thing is not telling them to breathe, and the muscles they're worn out, and they just stop breathing, and we have to help them. And it's just talking about increased transit of fluid is produced. That just means there's more inflammation, more trouble getting that gas exchange. So So we can put them on nasal cannula, CPAP, hood, don't know all that, we're gonna look at all that. Diagnostic evaluation, we can do x-rays on their lungs to see how they're doing. We can do blood gases to see how they're exchanging. The first thing we do when a baby comes out that's premature is we slap a pulse ox on them, that really does help, but then we listen to their lungs. So don't forget you're very good. We're gonna talk about lung assessment. Therapeutic, we're gonna give them surfactant. So how are we gonna take care of this? We're gonna give it to them. And on page 303, it shows a picture of what they mean by exudate, because they have endogenous, see exogenous versus endogenous. Exogenous just means we give it to them once they're born. So on page 303, there's a picture of a nurse giving the surfactant through a syringe. Endogenous means we give the mama a shot before she delivers of surfactant, and that helps the baby to go ahead and start producing it, getting more. They have found this is really, really good if we give it before they get into respiratory distress. So we're going to give it to them prophylactically is the term that we like to use. So the nurse's job, you're going to give the surfactant. You're not going to suction them for at least an hour after you give the surfactant because you don't want to bring it back up. You just put it down them, you want it to absorb. Monitoring the blood gases. Yes, you will be able to read blood gases and know what those are doing. Are they getting enough oxygen in? How is their O2? Are they breathing enough O2 out? How is their CO2? What is their pH? Are they getting acidotic? We'll get into that in the fluid and electrolyte lecture. I'm just saying, remember, that's what we're talking about here, is if they can't make that gas exchange in the alveoli, they're not going to be able to breathe on their own without our assistance. Once you've given them the surfactant, then the nurse in ICU or wherever is going to be monitoring the ventilator equipment, because you may have to adjust it a little bit. The respiratory therapist may do it, or you may have to turn down the oxygen a little bit because now they're breathing better. Don't want them to have too much oxygen. Okay, so evaluation and management. So how are we going to evaluate it? This is on page 304. I'm going to mention a few of the equipment that we use. You don't have to memorize this part, okay, guys? I just need you to know that there are different things you're going to see. So you have the CPAP, which helps them if they can do their own ventilating. You can also do an intermittent mandatory ventilation with PEEP, which means that it gives that positive end expiratory pressure. They take their own breath in, but the machine gives them a pository inspiration and expiratory breath. So it helps them get that end pressure that they need to keep things open and make that exchange. So the PIP on that one, I'm telling you, don't write this down, but you may see this in an ICU, is the max amount of inspiratory pressure allowed. So they have PIP, which tells them how much pressure that's set usually by the respiratory therapist. It says how much they need to have pushed in. And then you have a mean airway pressure, which is, it tells them how everything is averaging on inspiration and expiration. So one of the complications that we have with ventilators is they can get pulmonary interstitial emphysema, which is air. They can, air in a place it shouldn't be. They can get a pneumothorax, which is where the lung actually collapses. The alveoli are not opening up and they collapse. So when you do the nurse's role, your responsibility when it comes to CPAP and all this other stuff, you're going to make sure you're doing continuous respiratory assessment. How do they look? What's their effort of breathing? So when you think back to your fundamentals, and when we get over to the diseases part in chapter 26, we're going to go over it more, but think back on fundamentals. When you did a focused assessment of the lungs, and the first thing on the focus assessment is inspection. You look at them. Before you even took that stethoscope and put it on their chest, how are they looking to you? How are they positioned? Now with a baby, the position is nothing because they don't have the muscle tension yet to be able to lift themselves up to put in a tripod position. They're just going to look blue, or they're going to start looking like they're having retractions. and grunting. And I said we're gonna cover this more later on, but what does that baby look like? So what is your nursing assessment? What do they look like? Then the stethoscope goes on the chest. How do their lungs sound? On pages 122 to 123 in chapter 4 is just a really good pediatric pulmonary anatomical assessment. It's a good idea to know what those are. Where you're going to put your stethoscope, and it gives you some really good technical terms, make you sound real impressive when you're on that floor at OU and you chart mid-axillary line, auscultated, no lung sounds heard. You know what you're talking about because you've looked at that. I'm going to grab a drink. Okay. So the nurse is going to do the assessment. They're going to listen to the lungs. They're going to make sure that they are ventilating okay, that their pulse ox is doing good, that they are responding correctly to therapy. They're not having any complications. Continuous monitoring and close observation is the nurse's role when a baby has respiratory distress, because they might be in distress, but they can get in even more distress. Okay, got my backup started now, but hopefully the other one's still recording. I'm trying to tell you what the nurse's role is, because a lot of the questions that I see on Blackboard are good questions. I'm not saying that at all. I want you to understand the pathophysiology enough that you know what the nurse's job is, because that's what you're doing. You're not going to be diagnosing them with respiratory distress. You're going to be assessing them and helping them breathe. So if you need to know the pathophysiology enough that you can do your interventions, okay? So the next one is your meconium aspiration syndrome, and this is on page 306. And if you've seen a newborn or held a newborn or changed a newborn's diaper, you know that meconium is very dark, black, sticky. So when I see a meconium aspiration, I always think post-term baby. They're overdone. They're in the womb. They've been there for longer than 40 weeks. Now they're at the 42 weeks. The amniotic fluid is less, and they get stressed somehow. Either, and we don't know what happens first, the chicken or the egg. We don't know if they get stressed and then they poop or whatever, but they have a bowel movement in the womb, and then they breathe it in. They don't have as much amniotic fluid, so now they're breathing in their meconium. That meconium can go all the way down into the lungs, but we don't know how far it is yet. We just know that when the amniotic fluid, when the sac broke, there was meconium in it. So that alerts the nurse, oh no, we've got to be prepared with emergency equipment. Okay, something could happen. Excuse me. So they breathe it in, and then now you've got a bigger problem. You've got obstruction in the lung. You've got poop in the lungs. One of our students said that the other day, and it was just a perfect description. They've got poop in the lungs, E. coli, bad stuff. So when you see them, and in your book, on one of the pages, it talks about what can be done. You're going to aggressively suction them. That's the pediatrician. That's not the nurse, usually, unless you've been trained to do that. When the baby's head comes out, the doctor can look in their mouth and see if there's any meconium in there. They can kind of visual the throat, the pharynx, and see what's going on in there, and then they can suction. Our job is to suction the nose and the mouth because it's just so much trauma for them. So the baby, when they're born, if they have a lot of meconium, they cannot make that alveolar gas exchange. So they're gasping, they're grunting, they may not even be breathing at all, their cry may be weak. It just depends upon how much they swallow. Nope, not yet, okay. So how we're going to treat that is we're going to make sure they're breathing. We're going to get an x-ray. Once they're breathing, once we have them, either we have ventilate, they may have to just go ahead and intubate them and start ventilating if they don't breathe on their own. Okay, that's worst case scenario. But if they're breathing on their own, then we're just going to continue watching them and maybe give them what we call flow-by, which is where you just hook up an oxygen and you let the air blow in their face and see if they can do that. The whole time the nurse is looking at them. Are they blue? Are they pink? Are they retracting? Are they grunting? Are they crying for you. You want a good, throaty, lusty cry, because that helps them get that out. If they're not doing any of those things, then we're going to proceed with more care. They may have to go on ECMO. Just know ECMO is something that they do to help clean out the meconium. It's only at a few places, so they're going to be life-lighted from your rural hospitals. Might even be life-lighted from your city hospitals if they don't have an ECMO. It's just one of those things that helps them. Okay, so this is the one that's on 309, and all I want you to know is after they have respiratory distress, they can go into this syndrome called BPD, or bronchopulmonary dysplasia. And the definition is O2 requirement or mechanical ventilation after 36 weeks of age. They get dependent on the O2 because whenever they were born, it didn't get corrected soon enough, or maybe it was too bad to begin with. They needed more surfactant. They have found that surfactant has actually been, when we use it prophylactically, then the mother gets it in before the baby is born, and then when the baby gets it when they come right out and within the first 2 hours of life, they have seen the incidence of BPD go way down, okay? But again, they can't make that gas exchange. They are dependent on the O2. Some of them come off of it, some of them don't. Some of them get ventilators and they're on ventilators for the rest of their life. Some of them get O2 via nasal cannula. It just depends on how bad it was. So dysplasia just means that they have an abnormal growth or development. So it just means, so bronchopulmonary, so we're looking at the lungs, the bronchial and the pulmonary, dysplasia abnormal. That just means what we should be doing normally and automatically, not happening with these kiddos. They need extra help. The nurse's job is to make sure that the ventilators are kept at the lowest setting possible so we don't hyperoxygenate them. Let me see if that next one is, yeah. Yeah, okay, it is. I'll tell you what can happen if you give them too much oxygen. Make sure that the parents know how to do CPR when they go home, when the baby goes home, because they may be doing CPR on their child. The nurse is going to be checking blood gases and making sure the O2 is staying where it should be, delivering the surfactant as needed, and trying to help them wean off of the O2 if possible. So here are some of the complications on the respiratory they can happen just because of respiratory distress. They can happen because of ventilators. So this is on page 305. Is the nitrous oxide. The other things are just things we know. They can get a pneumothorax because the pressure settings on the ventilator are too high and it causes their lungs to collapse, or maybe their lungs are just not healthy enough and they collapse anyway. They can have a spontaneous one. Persistent pulmonary hypertension is exactly what it sounds like. The pulmonary system gets too high attention and it's really forceful and it causes pulmonary hypertension. Bronchopulmonary dysplasia, which we just talked about. Retinopathy of prematurity, which just means they have difficulty with their eyes. Too much oxygen can hurt their eyes. So we have to be careful. When I worked in the preemie unit, we had a preemie gathering every year, and it was really fun to see how well they were doing. But most of them had glasses by the time we saw them because they had a lot of oxygen when they were little, and it hurt their eyes. Some of the treatments we do are the inhaled nitric oxide. That's on page 305. That's just something that they're just coming into and says it really does help. The ECMO I already told you about, and then liquid ventilation, we're not even going to talk about that. So these are the conditions that can happen with a newborn. The postterm can have the meconium aspiration. The preterm can have it, but it's not as common. And then the apnea is usually with the premature baby. However, we will talk about in the infection lecture how if a term baby or a post-term baby has apnea, we investigate it. And it says that in your book. We'll talk about that more in infection. It usually means they're getting septic. If they stop breathing, a post-term, we're looking at them because something's going on. So don't just ignore it and go, oh, he's term, he's fine. No, there's a reason why he stopped breathing. We need to figure it out. Okay, now we're moving into chapter 26, and on page 883. So 883, this is just an overview of what we're going to be looking at. We're going to be looking at the respiratory system, and then we're going to break it down into the upper respiratory tract and the lower respiratory tract. And I'm going to give you some general considerations with all of them. So when you look at the upper respiratory tract, we're talking about the nose, the throat, the larynx, the trachea. So the oronasopharynx, the pharynx, the larynx, and the trachea. So if you ingest something or breathe something in, it could potentially start in the nose, but then it could go to the throat or it could go to the chest. So that's why we're looking at this all as one. And then the lower respiratory tract is going to be your bronchi, your bronchioles, and your alveoli. We're going to try to get all of upper today. We're going to look at the diseases and what to do about them. All right, so your infectious agents, and this is where I have to stop and give you a commercial. So on your viruses, viruses are smaller and they have to inhabit another cell. They cannot live on their own. They come into our body, they enter one of our cells, and then they set up shop. There's like a manufacturing plant, and they just start making more. So that's why with a virus, normally you get these general symptoms. I just feel bad. I just ache all over. I have a low-grade fever. I just want to sleep. So for your bacteria, those are usually bigger. They can live on their own, and they usually go to one spot. So that's why you're going to have the super bad sore throat, because it's bacterial. You're going to have a high fever. You're going to look, and I'm going to use the term over and over again, you're going to look toxic. You're going to look sick. You're going to look, your eyes are going to be kind of glossy. You've seen your children if they've ever had strep throat, and they just don't feel good. They just feel terrible. They don't want to drink. They don't want to eat. They just want to curl up in their bed. They don't want to play games. It's a different look, usually. Of course, there's always some exceptions. For treatment, for viruses, we usually try to treat them symptomatically. This I will say over and over again, so don't try to write down everything I'm saying. Viruses, we only have a few antivirals, so we try to save those for the children that are immunocompromised. Because we have overused our antibiotics and we're getting resistant to them, we don't want to get resistant to the few antivirals that we have. Bacterial, we do go ahead and give them antibiotics for it, but we want to make sure that we instruct the parents that they take the full regimen of it, and we'll talk about that more too. And so this is just an example of some of the viruses or bacteria we're going to be talking about, and I will mention some more specifically as we go on. So some of the complications you can see. So for infants younger than 3 months, they have the added benefit of having their mother's antibodies. For about 3 months, they have that protection, which is God's way of taking care of our little innocent babies. But they don't have protection from a lot of the diseases that are going on. So like right now, when we're discharging our new moms, and they've got older children, or they've got, family that want to come over, we got so many germs going on right now. We're going to tell them to stay in, kind of sequester yourself in the house. Don't take your child out to anywhere public because they don't have protection, because they've never had a cold. They've never had any of these other things, so they haven't built up those antibodies. They get some of mom's, which really does help them, but they still need to be protected. So from 3 to 6 months, their infection rate starts to increase. We're starting to give them some vaccines by that time. They've had some at birth, but now we can give them some more protection. Toddler and preschool ages, and I think I have a slide on, yes, I do, okay. So toddler and preschool ages, they're getting every cold around because they're more social. They're going to church, they're going to preschool, they're going to the playground, and they're seeing more kids that are older that have a cold, and they're getting them. Older than 5 years, and that's when they start getting the more serious bacterial infections, but we'll talk about that in a minute. They get increased immunity with their age because they've been exposed to more, and because they've been eating more, and they've got more immunity built up, basically. Some of the reasons why our respiratory is affected. So your respiratory tract, remember the respiratory tract that we talked about, nose, mouth, throat, lungs. So the diameter of their throat, their airways is smaller. They can get plugged up. They also have sinuses. They have a sinus when they're born, or sinuses, but not all of them are fully formed until they get to be school age. So they can get stuff trapped in their sinuses and get a headache. They have a short eustachian tube. Oh, there was a good page. Where was that? Oh, that's on another slide. I have that page number. So you can see the actual eustachian tube. So not only is it short, but it's horizontal. So it depends upon how the baby is being fed. Sometimes the fluid can stay there. When we get to the otitis media, we'll talk about that. Again, the resistance is lower. They can have allergies or asthma that can come up that can affect their respiratory system. Cardiac problems, we'll have another lecture on that. Cystic fibrosis, terrible disease, and we'll talk about that, how that affects the respiratory system. Daycare, and the reason they put daycare in there is just because they're going to be exposed to more. It's not a bad thing. Daycares are wonderful. My children were in daycare. They did fine. Seasonal things. This is just, most of them are more common during winter and spring, the changing of the seasons. The summer usually sees less flu, usually sees less those kind of colds in the summer, usually. Then just talk about a few more. Asthmatic bronchitis is more frequent in the cold weather. Don't need to know that. Just know there are seasonal things. And right now I call this RSV season. RSV seems to pop up around October and stay there for a couple of months. And one year, one of the hospitals, small hospital, we had 4 children admitted with RSV within 30 minutes. They got it and they get sick and they have to come in, and we'll talk about that. So what does it look like? It depends. The younger ones are actually a little bit sicker because they've never had any of these diseases before, so they have a little bit more trouble breathing. This is a general slide. There is, on page 884 to 885, are a list of observations. Those are the things that we're looking at to see how the baby is doing. I told you about that, the retraction. So when you look at their chest, and if you've seen an asthmatic child and you've seen their chest, you can see that they are sinking in some of their ribs, or maybe they have a substernal sinking in right below the xiphoid process. Or maybe they have, and so one of my students asked about the up above your clavicle, because you have lungs up there, you can have a sink. Sometimes they're just skinny, but they can have, if it's severe, and that it can sink in there. So we're observing. They have nasal flaring. They're trying to open up that airway, get more air in somehow. So they have the flaring. Your book has a picture of it, but it's so subtle. I'm like, I don't care how severe it is. Are they flaring? That's important to me. Head bobbing, mostly for the newborn, because they don't have the energy to hold their head up. Their head will fall forward if they're having respiratory trouble. Noisy breathing. That can be anywhere from snoring, because the passageways are getting narrowed, or even worse later on. Stridor. So there is a website you could go to, and it's called easyauscultation.com. I tried to do it yesterday, and you actually have to, it's free, but it's easyauscultation.com. I can post it to Blackboard, but it's free, but you can go in and you can say, listen to heart sounds or listen to lung sounds. You can go in and it'll actually give you the sounds that it sounds like. And it's pretty cool to listen to. I'll try to remember to post that. So the general symptoms, fever, anorexia, they don't feel like eating, they start having so much snot in their tummy, they have nausea and vomiting, diarrhea from the drainage, abdominal pain, cramping. These are just general clinical symptoms of a respiratory problem. Cough, sore throat, nasal blockage or discharge, and respiratory sounds, which we already covered. So this is your job, nursing interventions, and I will refer to this slide many times. This is slide 18. We are looking to see how much effort they're putting into their breathing. So if you're reading a test question and it doesn't say anything about there being grunting or nasal flaring, don't put that in there, okay? Don't add to the question, just answer the question. Fever management. So if they have a fever, we're going to give them ibuprofen. We're going to give them acetaminophen. We're going to try to bring that fever down. Promote rest and comfort. If they're having a problem breathing, they don't need to be up playing around. So you're going to have to be creative and come up with ideas to keep them down so their body can do its natural process, which is to heal. Infection control, washing your hands. And that's why it says that spread of infection. We're going to talk about that in a minute, but it's kind of the same thing. Promote hydration and nutrition. They don't want to drink. So you're going to have to get creative on what you give them to drink. You may have to give them their favorite drinks for a while and go, well, after they're done, we're going to stop drinking ginger ale. But you want to just try to get them something to drink and eat. Make the calories count. Try to get something that has some good, Pediatric's good. Family supported teaching, your nursing role in these next 48 slides are going to be teaching. Because you're going to be teaching the parents how to take care of them. Once they leave you, they've got to know what to do if. So we'll talk about that more specifically. Prevent spread of infection, we're going to talk about vaccines. We're going to talk about staying out of the community, keeping your baby out of the community, keeping your sick kid out of the community so we can get better. Provide support and plan for home care. You're going to make sure they have everything needed to take care of that baby. I'm going to stop here for a second. And under fever management, we do not give children aspirin. Do not give children aspirin. Anything under the age of 18, it can cause what's called Reyes syndrome. That's R-E-Y-E-S. It is a serious central nervous system problem, and it can cause encephalopathy, which is water in the brain. We don't give them Tylenol. We don't give them aspirin. The problem is there are some other medications, over-the-counter medicines that have aspirin in it, so you have to teach your parents how to look for those. Pepto-Bismol. I don't know if they do it still, but they used to have aspirin in it. That was one of the problems. Those are your general nursing care interventions that we will talk about. And when I say symptomatic control, that's slide 18. Okay. This is not a page number. This is just what we know as nurses, and you guys should know this. Newborn pediatric assessment, our biggest thing is we're going to maintain an airway, a patent airway. Can they breathe? Is their head flat? We're going to raise it. If it's a baby, we're going to adjust their chin so that they actually have an open airway. Because remember, their head's going to flop back and they're going to occlude, their tongue's going to fall in the back of their throat. Or if it's a child who has a debilitating muscular disease where they can't keep their tongue from the back of their throat, you're going to make sure they are at the optimal level to be able to breathe. So elevate the head of the bed. You're going to make sure that you have oxygen handy and suctioning equipment ready. If you go into a newborn nursery and they have the little, what I call them Ohio units, but they're the warmer bed, they will have an emergency equipment right there handy for you, just in case, because we're always prepared. And then you're going to observe for respiratory effort. Retractions, head bobbing, the same thing that we've been talking about. Rate, so you're going to count their breathing for a full minute if it's not an emergency. If it's an emergency, you're going to go ahead and treat the child. But if you're just doing an assessment, you want to count for a full minute. Because like I said, their breathing is not regular yet, and even children they start to get a little bit more regular on their breathing, but you're going to go ahead and count for a full minute. You want to know, is it irregular? Is it regular? How deep is it? And are they exchanging air? Can you tell that they're getting in and out, or is it shorter on inspiration and longer on expiration, or vice versa? Percussion. You remember that from your fundamentals, when you tap on the chest. It's always good to remember that. And palpation, do you feel anything going on? So diagnostics, we use x-rays to see if there's what's going on in the chest, because we can't see it on the outside. Blood gases, pulse ox. There's a couple of ones that I have not used, but I guess we're using them. A transcutaneous monitoring probe on the skin on page 886. I don't know if you need to know that. It's just something else that's used. And I think you've heard of capnography. That's another one of those monitors you can put on them to see how they are getting their carbon dioxide. How are they getting rid of it? Are they expressing the air out adequately? Okay, now we're going to start with upper respiratory infections. That was all of our general information. Now we're going to get specific. So this is on page 891. So your general information went from 887 to 891. Now your specific, starting on 891, and this is your nasopharyngitis, which is your cold. So this is your cold. Usually it's viral. I mean, it is viral. So you're going to treat the symptoms. Fever, antipyretics if they have a fever. Younger children do have it a little bit worse because they've never had a cold before, so it can make them feel really bad. But their fever is not usually as high, but you want to make sure their airway's open. They get nasal inflammation, so it's hard for them to breathe in and out. You can have like little drops that you can put in their nose. Don't know that, just that is one of the interventions we can do. The nursing interventions that you need to concentrate on are, because the nose gets wiped so much, it gets sore. We're going to watch for skin care. Nausea and vomiting, because they have repeated coughing or secretions. No real treatments, and the vaccines aren't really effective. So you're just going to treat the symptoms. I'm going to talk about pharmacological stuff on the next slide. They don't like you using over-the-counter meds for the pediatric patients because they can have side effects in them that are really not good for your child. So you want to talk to your pediatrician or your provider and find out what they want you to do. So one of the things that we take as adults is antihistamines, but children don't want to take those because we don't want to dry up the secretions. We want them to get out. Antipyretics for fever, that's good. Cough suppressants, we don't give cough suppressants. Even though that slide says cough suppressant for dry cough, normally we don't give a cough suppressant because we want them to cough it up. There are exceptions to every rule, but the general thing is don't give them cough suppressants. We want an expectorant. Decongestants, they say that the sprays or the drops are better than the pills. So if you use a decongestant for their nose that the doctor tells you to give, make sure you're only using it on that child. You don't keep it in your cabinet for the next child who gets sick. You just don't want to pass things around. And the cough thing is on page 892 if you want to look that up and see why. So pharyngitis is just, I have it on page 891. It's the same thing as nasopharyngitis, but it's just all in the pharynx. This is viral. You may have a fever, you may have a stuffy nose, drainage, decreased appetite, just like all the others. So again, diagnostic, take them to the pediatric, to your healthcare provider, or the mom has had enough children, she knows this is just a cold or a sore throat, we're just going to watch them. Quiet activities, fluid. Again, you're symptomatic. You can use a cool mist. They try not to let us do the warm vaporizers anymore because the vaporizers themselves get bacteria in them and can actually spread disease. So we're using the cool mist humidifiers now, rather the cool. And the coolness also can help them. And in your book, it talks about some children, if they have their window open, it helps, and it's cool out, that can help. And I agree. I happen to be one of those that have a lot of allergies, so the window open can also make me have more allergies. So it just depends on your child. So you're just going to treat the symptoms. The next one is the serious one. And then we're going to talk about the difference. So this is on page 893. This is bacterial. And remember what I said about bacterial? It makes them look toxic. They act sicker. They have a higher fever. And the biggest problem is they get this group A beta hemolytic strep, which is GABHS, so it's group A. They can get other sicknesses from having strep throat. Rheumatic fever, which affects the heart, the joints, the kidneys, the central nervous system. Scarlet fever can also be manifest from acute strep, but we don't see it as much in the United States. So why are we covering it here? Because NCLEX is worldwide. Just in case they throw something out there for you, scarlet fever is something that you can get from group A strep. It can look similar to pharyngitis, but it's more severe. The throat is really sore, and then when they look at it, a lot of times it is covered in the little white patches. So if you go into the doctor and your child is sick, or your provider, because there's other people besides doctors, there's nurse practitioners, they look at the throat, they're probably going to do a strep test no matter what, just in case. Because we don't, if it's bacterial, we want to treat it. If it's viral, they're going to say, and I hated it when my doctor would always say this, he'd go, well, it's just viral. That doesn't mean they're not sick. It just means we're not going to give them antibiotics. You're going to treat the symptoms. We, in the United States, we like antibiotics because they make us feel better, but we're overusing them. So you're going to make sure, so what is your job? You're going to obtain the throat culture usually. You're going to educate the parents about giving, and so this is the pain in the neck. The penicillin that you're giving, let me see if it's on here. Yeah, here's the next slide actually has your pharmacological stuff. So they're going to usually get it, and it's usually every 6 hours, but it's several times a day. They're getting penicillin because they need it, like usually it's 250 milligrams or whatever, and they're going to get it for 10 days. And my mom used to set an alarm and wake me up in the middle of the night and give me my medicine. I mean, she was the best in the world. I think I just manipulated it around so that I could sleep a little bit. So you're going to make sure your parents know to take the full dose. They're going to feel better after 24 hours. They may be running around after 3 days, but it's a 7 to 10 day regimen, and they've got to take it the whole time. So you want to impress upon them the importance of taking it till that whole bottle is gone. There is one you can give a shot. The nice part is that it's one injection. The bad part is that it stinking hurts. They can put a deadener in it, but it still hurts. I mean, it hurts afterwards. You can't give it IV. It has to be given IM. And if they have a penicillin allergy, they can have erythromycin. And then there are other medicines they can give if that one's not working. So another thing that the nurse needs to know is make sure the child throws away their toothbrush after they've been on the antibiotic for 24 hours and they get a new one, because that germ is still there on their toothbrush. If they have any orthodontic appliances, they want to clean them really, really good. Really, really good. Wash thoroughly. And you want to avoid close contact with people that are immunocompromised, which are your little babies, anyone with a chronic condition, your elderly. You don't want them to get this. Oh, and this is interesting because we used to just look at this, the mode of transmission and just go, yeah, it's droplet transmission. But since Corona, we've got a whole different understanding about droplet transmission, right? We're wearing masks now. We understand about droplet transmission. This is respiratory droplet. That means when I talk, when I sneeze, when I cough, when I sing. If I'm sick, I can infect you with it. So that means a whole different thing to us. And you'll notice now nurses are actually wearing the PPE that they're supposed to be wearing. Before, they just kind of went, oh, well, it's just this. We're spreading things. And we've gotten, that's one good thing, I guess, we can say about the corona. Okay. Tonsillitis. I didn't put page number, but I know it's the next page. Yes, page 894. So I thought this was interesting. I had never really looked at where tonsils were, but on page 894 is a great picture, and you can see there's several different tonsils. So if they get inflamed, you can see how it is going to affect how you breathe, right? How you swallow, how you do anything. That's why when they get swollen, we don't like it. We're hurting. You're You're gonna treat it symptomatically unless it's bacterial, but we're gonna assume it's viral. So for the throat, it really does work. For warm, salty gargles really does work. It soothes it. I swear by it. Throat lozenges, something to soothe from all the drainage going on there. Analgesics, something for the pain, your acetaminophen, your antipyretics if they have a fever. And it said opioids for pain, which I thought was weird, but I'm assuming that means with surgery, because usually you don't need opioids for a sore throat. So we're just gonna assume, but I've not had a sore throat that bad that I had to have surgery, so I don't know. So here is your nursing. So surgical, it's controversial. We used to take out tonsils all the time, but now they're being more specific on actually who can have it. So after surgery, hang on, let me get a drink. The nurse's role after surgery is to make sure there's no bleeding, no active bleeding. You're gonna have the head of the bed up. You wanna make sure that they can get the secretions down, because even though they have the tonsils out, because of that surgery, they're still gonna be swollen and sore. So you wanna make sure that they have the optimal airway, like we talked about earlier, so the head of the bed is up. They say a throat, an ice collar is good. You can put like a little cold pack around the ice, and that helps with the swelling. When you look in the mouth, you're gonna do so very, very carefully so as not to interfere with the surgical incision and make it bleed. So if the parents are with them and they go, oh my goodness, he has he's bleeding, ask to look at it first, and if it's dark brown and dried, we expect that. But if it's bright red, we're gonna further investigate. You're gonna assess it more. Suction, we only suction if absolutely necessary, and we do it very, very gently, because we don't want to mess with that incision. And here's the fun part. You don't want them coughing. Usually their throat is so sore they don't want to cough. So I'm like, I can't stop myself from coughing, but you're gonna try to get them to sip on some water so they don't get a dry throat. And when they clear their throat, because that can be a lot of pressure on that incision and can open it up also, and you can have a hemorrhage. Blowing their nose. You don't want them blowing their nose, so we're gonna make sure that area is clear. You don't want them vomiting. So when they get back from surgery, head of the bed is up, we're looking at the site, we're making sure they're not doing anything to cause more pressure in their throat. We're also going to adjust their diet slowly. So we're gonna start with some fluids and move up, because if they're nauseated after surgery and they throw up, that's gonna open up that incision. So we're gonna advance it as tolerated, but slowly. You start off with liquids and move up. We want to make sure that the swallowing has returned well enough before they do start drinking oral fluids too. Are they swallowing, and can they get it all the way down? We don't want them aspirating. You're going to teach the parents about home care. Avoid foods that are irritating, too hot, too spicy. Even if they're begging for that pizza, that may not be what they need right now. So you're going to have to try to find something else that's a favorite. Avoid gargles. You know, I said that gargling can help with your sore throat, but this is surgery, so we're not going to gargle with salt water, because that could irritate that incision and make it open up. Avoid coughing. Use analgesics and opioids for pain relief. You want to limit their activity to decrease the bleeding. When we get up and we move around and we're getting really, really active, our heart rate starts racing, and that can also cause a hemorrhage. So we just want them to rest. It's a great excuse to watch all the SpongeBob they want. And then I'm just going to finish with this, and then we're going to take a break. So we've got them up. We're observing. How is their swallow? We want to prevent the recurrent bleeding. These are the nursing interventions. Maintain a quiet environment so they're not agitated or running around. Minimize their agitation and crying. So you may have to medicate them to make sure that they are resting. No suctioning, and offer comfort. They want their mom or their dad, or whatever age they are developmentally, they need something with them to help them with their comfort. All right, we're gonna stop here for 10 minutes, and we'll get